Hello and welcome back everyone. So continuing our discussion about the management of cardiac arrhythmias, in this video we will talk about the junctional rhythm. So in normal heart, the electrical activity originates in the sinoatrial node, which is the default pacemaker, and then the electrical activity depolarizes the atria, and then it passes from the atria through the atrioventricular node and into the bundle of His, from which it travels along the Purkinje fibers to reach and depolarizes the ventricles. And this is the sinus rhythm. So as you can see in this picture here, we have the sinoatrial node, which is the SA node, which is located in the upper right of the right atrium, and it acts as the default pacemaker. So the electrical activity starts in it, and then it depolarizes the atria, and then it moves on to the AV node, which is a separate cardiac pacemaker, which acts to deliver the electrical activity to the bundle of His, and then to the right and left bundles, and then into the Purkinje fibers, where they depolarizes the ventricles, and that is for the heart to work. Now in junctional rhythm, which is also called the nodal rhythm, the electrical activity originates in the atrioventricular node or in the His bundle, and those two regions described as the junction between the atria and ventricles. So the junctional rhythm can be called junctional or can be called nodal, and then the electrical activity travels to the atria and ventricles and depolarizes them. So in junctional rhythm, the electrical activity starts in this area here, which is the area of the AV node and the His bundle. So the electrical activity starts here, and then it moves on to the atria to depolarizes them, and it moves to the ventricles through the right and left bundles and into the Purkinje fibers to depolarizes the ventricles. And in junctional rhythm occur in cases where the SA node become dysfunctional, and that is due to many causes that will be mentioned in a separate part of this video. Now let's talk about the ECG characteristics of the junctional rhythm. So the junctional rhythm is a regular rhythm with a normal QRS complex, because the impulse still travels down the bundle of His and through the right and left common bundles, so the QRS will not be wide, and the junctional rhythm can present with either bradycardia, normal heart rate, or tachycardia. So as we can see in this picture here, we have a 12-lead ECG of a patient with junctional rhythm, and we can see that the rhythm is regular. So the distance between every two QRS complex is the same, and the QRS complex is normal, so it's not wide, and it can present with bradycardia, normal heart rate, or tachycardia. In this case, it presents with a heart rate of 50, so it is bradycardia. Also in the ECG characteristics, we have the P wave, and regarding the P wave in the junctional rhythm, there might be no P wave, and this might be due to failure of the electrical activity to pass to the atria, or the P wave is hidden within the QRS complex. The other variation in the P wave is that the P wave might be inverted, and this might come before the QRS complex, and the P wave is inverted due to retrograde flow of the electrical activity to the atria. So since the electrical activity starting in the AV node or the His bundle, the impulse is traveling retrograde backwards into the atria. So the P wave will be inverted, and the P wave might come before the QRS complex. So here we have the P wave and then the QRS complex, and this means that the atria will contract before the ventricles. So the impulse will travel to the atria first and then to the ventricles. The other possibility is that the inverted P wave can come after the QRS complex, and this means the electrical activity flows to the ventricles first, then to the atria. So the QRS complex can come first and then the P wave. And this means that the ventricles will contract first and then the atria second. So the electrical activity comes to the ventricle first and then to the atria. Now, depending on where the rhythm originates in the AV node, the atria can contract before the ventricular contraction due to retrograde conduction, or the atria can contract during the ventricular contraction or after the ventricular contraction. And if there is blockage between the AV node and the SA node, the atria may not contract at all. And on this example here, we cannot see the P wave. And this could be that the P wave is hidden within the QRS complex, or there might be no P wave at all. Now remember, the junctional rhythm can occur in case where the SA node becomes dysfunctional. Now, depending on the level of the rescue pacemaker within the junction, the junctional rhythm rate is different. So we have junctional bradycardia, and that is when the heart beat at a rate less than 40 beats per minute. And we have junctional escape rhythm when the heart beat at a rate between 40 and 60 beats per minute. And then we have accelerated junctional rhythm, and that is when the heart beats at a rate between 60 and 100 beats per minute, and this is common in digoxin toxicity. And we have junctional tachycardia, and that is when the heart beats at a rate above 100 beats per minute. Now here we have some examples of junctional rhythms. So in the first one, we have junctional bradycardia. So we can see that the QRS complex is normal and we don't have a P wave, and the rhythm is regular and the rate is around 37 beats per minute. So this is junctional bradycardia. In the second example here, we have accelerated junctional rhythm. So we can see that we have a normal QRS complex and we have inverted P wave before the QRS complex, and we have a regular rhythm, but then the rate is in the 70s, so this is accelerated junctional rhythm. In the third example here, we have junctional tachycardia. So we can see that we have a normal QRS complex and we have an inverted P wave before the QRS complex, and then we have a regular rhythm, and then the rate is above 100, so this is junctional tachycardia. Now let's talk about the causes. So any disorder that impairs the SA node leading to decreased automaticity or less automaticity than the AV node in cases of sinus bradycardia or SA node exit block or AV block can potentially lead to junctional rhythm. And some examples include chest trauma, ischemic heart disease, like in cases of acute myocardial infarction, and in sick sinus syndrome. So in sick sinus syndrome, there is sometimes severe bradycardia that would lead to decreased automaticity of the SA node, means the AV node might take over and lead to junctional rhythm. Also in cases of myocarditis, hypothyroidism, and hyperkalemia, and muscular dystrophy, and other neuromuscular disorders. And in cases of radiation therapy, radiation might impair the SA node, and collagen vascular disease, and medications such as clonidine, reserpine, adenosine, cimetidine, antiarrhythmic drugs class 1 to 4, lithium, amitriptyline, beta blockers, ivermectin, opioids, and digoxin. Also vasovagal stimulation because it leads to bradycardia, and carotid sinus hypersensitivity also lead to bradycardia, and inherited channelopathies because the SA node has channels in it, and Lyme disease and rheumatic fever. Now there are some notes to pay attention for. So if the ventricular rate is too slow, myocardial or cerebral ischemia may develop, and when alternating rhythmically with the SA node, the junctional escape beats may cause bigeminal or trigeminal rhythms. Now let's talk about the presentation. So presentation varies according to underlying cause, and if the patient is presenting with decompensated heart failure, then symptoms include shortness of breath, chest pain, and peripheral edema, and patient with rheumatic fever present with heart murmur due to damage to heart valves, and they also present with fever and joint pain and rash. And some patients present with generalized complaints such as dizziness, fatigue, syncope, and palpitations. Now let's talk about the treatment. So isolated infrequent junctional escape beats usually do not require specific treatment, and if junctional rhythm is producing symptoms, you treat the underlying cause, and in unstable patients with junctional rhythm causing bradycardia, you give atropine 0.5 milligrams IV every 5 minutes to a total of 3 milligrams, and this will accelerate the SA node discharge rate and enhances the AV nodal conduction. And you can use transcutaneous or transvenous pacing in unstable patients unresponsive to atropine. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And you can support more by joining the channel using the join button near the subscribe button down, or using the link in the description of this video. Thank you for watching, and peace.